We are shocked and deeply saddened to announce the passing away of one of the Guardian founding fathers, Dr. Chandravadan Kantilal Vora, who was the father of CCI West Zone Governor Dr. Agam Vora. Dr. Chandravadan Kantilal Vora was a pediatrician and general physician who was serving in the Borivali area of Mumbai, which is one of the most economically challenged areas. Dr. Vora rose to fame by the virtue of his goodwill and service towards those most in need. He lived his life with simplicity and inculcated sober values in his children. Dr. Vora was loved, adored, and respected by all, and his loss is mourned by everyone. Chest Council of India joins Dr. Agam Vora and his family during this darkest hour to pay tribute to his father, to pray for Shanti for the departed soul, and to pray for strength for the bereaved family. We will now observe 1 minute silence, and the webinar will begin thereafter. Om Shanti.
Good evening, everybody. Deepest condolences to Dr. Agam Vora, our dear friend, for passing away of his wonderful father. We all really are equally grieved by this unfortunate event. And deepest condolences, heartfelt condolences from all of us, dear Agam. Om Shanti. With this, I would like to start today's webinar, which is going to be a very, very interesting webinar, the one of its kind, something that we all want to know and we keep on learning about respiratory physiology. It is something which is just so vast. It is something like space. You just don't know how much is really within, but we are trying to unearth some of the facts which can actually help us become better pulmonologists and improve our practice. So today's webinar is on very, very interesting concept, respiratory physiology, and we'll try to talk as much as possible about its clinical application in our day-to-day practice. I'm Dr. Amita Nene. I'm a consultant pulmonologist and head of department at Bombay Hospital, Mumbai. And with me, I've got the most fantastic, most amazing, star-studded panel of wonderful colleagues and brilliant doctors who are going to help us improve our knowledge in respiratory physiology. I would like to start introducing my very bright panel with the most sparkling star in the universe of respiratory medicine, none other than Dr. Chhabra, who absolutely requires no introduction at all. He is an ocean of knowledge. He is the revered and the most loved teacher across CCI, across India, and we all keep on learning every day from every post that he puts up. He loves to teach, and we are really lucky to have Dr. Chhabra with us. He is the former director, professor, pulmonary medicine at the very famous VP Institute, Delhi, and he is the emeritus consultant, pulmonary medicine specialist at the Primus Super Speciality Hospital, New Delhi. Welcome, sir. Looking forward to. Thank you for gracing us. We are so happy to have you with us.
Thank you so much.
After Dr. Chhabra, let me change the faculty. So now we have with us Dr. Amit Gangwani, a brilliant cardiologist who I've had many opportunities to interact in the past with. And every time he's kept on increasing my knowledge and he's helped me improve my patient's management. He's from Ahmedabad. He's a consultant cardiologist at the UN Mehta Institute of Cardiology and Research Center. A brilliant doctor, a brilliant cardiologist who loves to teach, loves to learn. So welcome, Dr. Amit Gangwani. Okay, then coming back to my faculty, we have Dr. Anuradha Shah, a very, very dear friend of mine. I know her ever since I was doing my residency. I used to call her ma'am before. Now I call her with her first name. I call her Anu. A lovely girl who is a half marathoner, who is seriously fit. Every time I see her, I feel actually like I'm in awe of her. A brilliant pulmonologist, vast knowledge. Sleep medicine is her absolute passion, though she's excellent at everything she does in medicine. So, in addition to sleep, she practices every aspect of pulmonary medicine and she excels at each of them. So, she's a consultant pulmonologist and sleep disorder specialist at Bhatia Hospital, Mumbai. And she's also the partner of Sleep Associates. Welcome, dear Anu.
Thank you, Amita. Very, very. Thank you so much.
Yeah. After this, I'd like to talk about, I want to say that while I've been doing medicine, in all my years of medicine, if there was one subject I really was seriously in love with, it was physiology. And I always want to become a physiologist, and Guyton was really my mecca. I thought there was no other book but that was better than Guyton, not even Fishman, not even Harrison. I thought Guyton was it. And therefore, automatically, I'm in awe of those people who are physiologists. And I'm absolutely so honored and I'm very thrilled that our Dr. Krishna, Dr. Atri, Dr. Kirat, and all the other webinar masters have decided upon calling a physiology specialist to help us understand respiratory physiology. And for this, I would like to invite Dr. Jagadamba. So she is an associate professor in physiology at the Department of Physiology at Sir Devraj URS Medical College at Kolar. She's going to really help us understand so many important aspects about physiology, which we've always wanted to know. Welcome, dear Dr. Jagadamba.
Thank you.
Thank you for being on board.
Thank
Now
you.
I would like to introduce a very beautiful, a very bright, always smiling, lovely pulmonologist who also is a brilliant singer and was a part of Palmo's Got Talent at NAPCON Varanasi. We have none other than Dr. Ankita Mohanty. So she is basically, she's just finished her MD medicine. So she's really she's just finished her MD respiratory medicine and she is just so full of her respiratory physiology knowledge. I think she's going to be the one who's going to contribute maximum in improving our knowledge. So she is basically finished her respiratory medicine from SN Medical College, Jodhpur. And now she's senior resident there finishing her bond. So welcome, dear Ankita. Welcome aboard.
Thank you, ma'am. Thank you, ma'am, for having me on this.
So we are very, very happy and we are very, very grateful to each of our wonderful panelists to being on board. And now I would like to start our very, very coveted, very, very interesting webinar on respiratory physiology. So first question, let's start with basics. And therefore I would like to come to the panelists who I came to know the first when I was doing respiratory medicine. So none other than Dr. Anuradha Shah. So dear Anu, can you please tell us about control of ventilation, control of respiration?
Thank you, Amita. And yes, back to funda, back to basics. So ventilatory control is regulated by a very tight feedback, which allows very, very small changes in PO2, PCO2, and pH under all physiological states, whether it's sleep, whether it's rest, whether it's exercise. And also associated with reflexes from the airways and the lungs, which influence this respiration. So the respiratory system actually maintains a very wonderful homeostasis by integrating chemical, metabolic, and mechanical inputs, which adjust the ventilation motor output to meet all these demands. Now, we all know that breathing basically starts from the center in the medulla, the dorsal respiratory group. Inspiration occurs, signals are sent to the respiratory muscle that allows steady state ventilation, preventing gasping, and expiration is passive during quiet breathing and results from the elastic recoils of the lungs and the chest wall, right? We know all this. But how is our ventilation controlled? And I think the most important regulation of this respiration is from chemical receptors, chemical. There are also non-chemical inputs to respiration, mechanical inputs, but the chemical is the most important. Of the chemical receptors, it's the central and the peripheral chemoreceptors that are most important. As the name suggests, the central chemoreceptors are present in the brain, next to the brainstem, and they respond to signals of elevation in carbon dioxide or in the hydrogen ions in the CSF. While the peripheral chemoreceptors basically, so any hypercapnia or acidosis would send triggers from the central chemoreceptors to increase the rate and depth of breathing and wash out the carbon dioxide. Similarly, the peripheral chemoreceptors are present in the carotid bodies and the aortic arch, and these respond to oxygen levels. Predominantly, they are also augmented by PCO2 levels. So we know that the oxygen dissociation curve is curvilinear, and till the PO2 drops below 60, it's curvilinear, and then the slope just declines very rapidly below a PO2 of 60. So hypoxemia again triggers. So afferents are triggered to the sent to the respiratory center, and then efferents to the muscles. So there's an increase in rate and depth of breathing. So the most important regulator of ventilation is the peripheral and the central chemoreceptors. There are mechanoreceptors which are found in the smooth muscles of the lungs. There are also J receptors. There are also other receptors which are found, the rapidly adapting nociceptors which are present in the respiratory epithelial cells. And all together, all these basically help in integrating ventilation. So, yeah. Okay.
Yeah, you want to add something?
Just few things, just one point. So signals also can be overridden from the cortex, especially in situations like pain and anxiety, or if you're yawning or you're coughing. So signals are also overridden from the central cortex. Okay.
Yeah, that was a wonderful answer. I think I kind of absolutely went through my entire physiology of ventilation and control of ventilation. Thank you, Dr. Anuradha. So I just want everybody to know that if a patient is breathless, it does not mean it is the lungs alone. It could be right from the brain to the diaphragm, to the heart, to the muscles, or anxiety or pain. So this is a very important point, that a breathless patient not necessarily is a lung patient always. Taking a clue from this very important point made by Dr. Anuradha, I would like to now go to our master, Dr. Chhabra. When I talk of the word master, I can only think of Dr. Chhabra, whether this webinar or it's anything.
Humbling, really humbling.
So, Dr. Anu gave us very important information. So I would like to ask you, what are the pathophysiological mechanisms of hypoxia and hypercapnia?
I think Dr. Shah has given a very wonderful description, nutshell of how ventilation is controlled, and she referred to the alterations in blood gases as the main drivers for the ventilatory drive. Before I go into mechanism, let me define a few terms for our audience, because there is sometimes confusion, like what is hypoxemia, what is hypoxia, what is respiratory failure. Now, so if you permit, I'll start with those definitions first. See, hypoxia means deficiency of oxygen, which is at the tissue level, right? Where our oxygen is utilized, that is a mitochondria. Hypoxemia means deficiency in the blood level. So that is once it leaves the heart into the aorta, from there the hypoxemia concept. So emia means blood. Now, our normal PaO2, arterial PaO2 is in an adult 80 millimeters mercury plus. When it starts falling, and Dr. Shah mentioned the oxygen dissociation curve, then the saturation falls. But reduction in the PaO2 is not a respiratory failure. So our respiratory failure doesn't begin till it falls down to 60. So that is a distinction between hypoxemia and respiratory failure. That respiratory failure is a PaO2 less than 60 millimeters, and hypoxemia is a PaO2 less than 80 millimeters. So mild hypoxemia is not respiratory failure. So in terms of pulse oximetry, because that is the bedside test, any saturation less than 90% indicates respiratory failure. Any saturation less than 95% indicates hypoxemia. Right. So with that background, now coming to the mechanisms, hypoxemia and hypercapnia, they have distinct mechanisms, although there will be conditions where both are found. So like we have type 1 and type 2 respiratory failure. So type 1 respiratory failure is hypoxemic respiratory failure with a normal PaCO2 or reduced PaCO2. Whereas type 2 is hypercapnia and is always associated with hypoxia. So you cannot have hypercapnia alone with a normal oxygen. So that is type 2 failure. So now hypoxemia, one mechanism can be that we are not getting enough oxygen. FiO2 is reduced. For example, in garages where a motor car is running and carbon monoxide accumulates, the oxygen in the atmosphere goes down. So when the oxygen in the atmosphere, so that is reduced FiO2. Or in anesthesia machine or in a ventilator, if your oxygen supply goes wrong, FiO2 goes down. So that will be a cause because the supply to the lungs is reduced. Second would be a reduced ventilation. So any mechanism that reduces the ventilatory drive, which so beautifully explained by Dr. Shah, for example, overuse of sedation, head injury, deep anesthesia, so that depresses ventilation. In clinical conditions, we see a condition called obesity hypoventilation syndrome. So these patients, in spite of having a normal lung, because they are hypoventilating, so they have reduced oxygenation. Then, so in both conditions, reduced FiO2 and reduced ventilation, lungs are normal, but yet hypoxemia and respiratory failure can be there. Then in diseased lungs, the basic mechanism or most causes of hypoxemia or type 1 failure is a ventilation perfusion mismatch. So this ventilation perfusion mismatch can be there in both airway disease as well as in parenchymal or chest wall diseases. So here we are referring to alveolar ventilation because on the other side of the alveolar capillary membrane is the pulmonary perfusion. So if these are not matched, so too much of ventilation and no perfusion is a wasted ventilation. Under ventilation and normal perfusion, again, there's not much oxygen to take. So that is ventilation perfusion. Then there are true shunts, left to right shunts, which can be at a pulmonary level like an AV malformation or in congenital heart disease where there will be left to right. The distinction between ventilation perfusion imbalance and true shunt is that true shunt is not responsive to oxygen therapy. So if so oxygen therapy is not the treatment for left to right shunts. Then diffusion impairment, where there is a disease of the alveolar capillary membrane that contributes to diffusion impairment in all the interstitial lung disease, especially during exercise. So these are 5 basic mechanisms of hypoxemia.
Wonderful.
Hypercapnia has a very good relationship with alveolar ventilation. There's an equation. There are 4 respiratory equations of great significance, and one of them is the relationship between alveolar ventilation and PaCO2. And there's an inverse relationship. So whenever there is hypoventilation, CO2 is bound to go up. In fact, we use this information to correct our ventilation settings. Supposing your PaCO2 is off the mark and you want to improve it. So the best thing is to improve ventilation, and that will bring down so that is the inverse relationship. So any condition which causes hypoventilation, again, central hypoventilation or respiratory muscle weakness or an extreme of ventilation perfusion imbalance causing alveolar hypoventilation, so all that will lead to hypercapnia, because hypercapnia leads to underventilation, and there is an alveolar gas equation which determines the capital A, the alveolar oxygen, so that is reduced. So hypercapnia is always associated with hypoxemia. So hypoxemia can exist alone, hypercapnia will exist with hypocapnia. Major mechanism for hypercapnia is hypoventilation.
Wonderful. This was absolutely a perfect and a complete answer. Thank you so much, Dr. Chhabra. I would just like to give one clinical tip to all the listeners, because sometimes we wonder that we are doing saturation these days. We are not doing that much ABGs because pulse oximeter is like a stethoscope. All of us always have it. So the thing is that often people ask me that, when should we suspect hypercapnia in a patient who has come to us? So I just basically want to tell you that even if the patient is a case of COPD, who are usually, once the disease advances, they are type 2 respiratory failure patients who tend to retain carbon dioxide. So a very important tip is that if the patient's saturation on room air while sitting comfortably is 95% or more, this patient's carbon dioxide is definitely normal and you don't need to do an ABG of this patient. So for example, sometimes we have patients who have obesity hypoventilation syndrome or they have COPD and they are actually on respiratory stimulants. For some reason, when they got discharged, they've been put on it. And when they come, often money is a problem or somebody is not available to really collect an ABG. And then you're not really sure if the patient's PCO2 will be fine or not. So the patient's saturation on room air is 95% or more. This patient's PCO2 is definitely normal. And this is something that can help us if it's not possible to collect ABG immediately. Thank you, Dr. Chhabra. This was a fantastic answer, telling us everything about the mechanisms of hypoxia, hypercapnia, telling us the basic difference between hypoxia, hypoxemia, the definition of respiratory failure, that your saturation has to be less than 90% for you to call it respiratory failure, and the PO2 has to be 60. So thank you very much. With this, I would like to come to Dr. Amit, the cardiologist amongst us. So Dr. Amit, there's something which is known as hypoxia vascular response. Can you please elaborate and educate about this and give us some clinical examples?
Sure, ma'am. So first of all, my job is done very easy by Dr. Chhabra sir and Anu ma'am, because they have cleared the first part, that is hypoxia. What does it do? So I'll come to the vascular response and I'll just show some few slides, which I'll take a minimal amount of time.
Sure, you can share screen then.
Yeah. So is my screen visible?
Yes, yes.
Yeah. So hypoxia vascular response, basically I'll be just dealing with three different types of response in this. One is what happens in acute hypoxia, what happens in chronic hypoxia, and when there is hypoxic vascular response, what happens at the histopathological level. So hypoxia, as we know, is caused by myriad of conditions, that is atherosclerosis, cardiac dysfunction, pulmonary parenchymal disease, thrombosis, pulmonary hypertension, etc. So when the patient comes with acute hypoxia, there is direct response and an indirect response. Direct response to hypoxia is pulmonary vasoconstriction as well as systemic vasodilatation. Now, this difference in pulmonary and systemic vascular response to hypoxia is mainly because of difference in the potassium channels which are present in the pulmonary circulation, which are oxygen sensitive potassium channel, as well as potassium ATP channels which are present in systemic circulation. Indirect effect is whenever the PaO2 goes below 60, the peripheral chemoreceptors are activated, and then they cause increase in the ventilation, causing respiratory alkalosis, as well as they activate the sympathetic nervous system, causing increase in the heart rate, cardiac output, and the blood pressure. So this is what acute vascular response to hypoxia is. When this continues for a prolonged period of time, chronic hypoxia leads to pulmonary vasoconstriction. Pulmonary vasoconstriction then undergoes remodeling, which occurs mainly at the vessel wall levels, which causes pulmonary hypertension, which leads to mismatch between the RV function as well as pulmonary coupling due to increase in the afterload, causing cor pulmonale, and ultimately leads to increased edema. Not only this, the hypoxia itself can affect the left ventricle because of chronic oxygen deprivation, can cause decrease in the left ventricular ejection fraction, can cause a lot of arrhythmias, especially atrial fibrillation, which can affect the left-sided heart also. What happens at the microvascular or at the histopathological level? So basically, as we go from the main pulmonary artery towards the capillary, the response is slightly different. So in the main pulmonary artery, usually there are a lot of different kinds of cells are there in the media. So the smooth muscle cells, which are well differentiated, continue to perform their own function, which is to maintain contractile and hemostatic function. However, the other cells, which are non-muscle cells or the immature smooth muscle cells, they undergo heightened proliferation, migration, as well as secretory action. They migrate from the media towards the adventitia as well as intima. Also, they secrete a lot of metalloproteinases, especially collagen and elastin, thereby thickening the vascular wall. In branched pulmonary arteries and all, where the media has got smooth muscle cells alone, these muscle cells are resistant to the different stimulus. So in this case, the adventitia has a lot of other cells which take over the various functions, like fibroblast gets converted to myofibroblast, as well as progenitor cells get converted to mesenchymal cells, and they proliferate into the media and intima, causing thickening and ultimately vasoconstriction, which may not be completely reversible. Even at the alveolar level, the same thing happens. Here, mainly the recruitment comes from the circulating leukocytes, which have got special characteristics, they are termed as fibrocytes, which get converted into fibroblasts, and then they assume the mesenchymal properties. So all in all, the response here is, so ultimately hypoxia becomes, when it is prolonged for a longer state of time, it leads to chronic inflammatory state. And what has caused hypoxia? Hypoxia will further worsen this. That means due to chronic inflammatory state, it will cause more atherosclerosis, more coronary artery disease, cardiac dysfunction. It will, because of the stagnation and increase in the peripheral vasculature, the stagnation of blood will lead to venous as well as arterial thrombosis, and it will lead to pulmonary arterial hypertension. So this is all the mechanisms.
Dr. Amita, your mic.
I'm sorry. Yeah. Thank you so much for this complete, elaborate answer, which was very, very visual. So it became very difficult for us, very easy for us to understand the difficult concept of hypoxia vascular response. Thank you very much. So I would just like to tell everybody that Dr. Amit very rightly pointed out that if there's hypoxia, there's pulmonary vasoconstriction, and that leads to pulmonary hypertension happening, which later leads to cor pulmonale, etc. So I would just like to add two things, which was not a part of the question, but just by the way, information to everybody, that just like hypoxia causes pulmonary vasoconstriction, so does hypercapnia, and so does polycythemia. So these two things also contribute to pulmonary hypertension. So if we want to make sure that a patient of pulmonary hypertension doesn't progress into cor pulmonale, please also correct the polycythemia and also correct the PCO2 also, if it's increased, in addition to correcting the reduced PO2. After this, I'd like to come to Ankita, our young, bright pulmonologist, full of knowledge. So, dear Ankita, please tell us about the transport of oxygen, because we all are talking about hypoxia, mechanism, vascular response. So, you please tell us what is the transport of oxygen and what is the toxicity of oxygen? We all have spoken about low oxygen. You also tell us about high oxygen.
Thank you, ma'am. Coming to transport of oxygen, oxygen is majorly transported in two forms, a bound form and a dissolved form. But the bound form, that is bound to hemoglobin, is the majority mode of transport of oxygen. So when we chart this oxygen and hemoglobin transport mechanism, as already said by sir, it forms the oxygen hemoglobin dissociation curve. Now, this curve attains an S shape or a sigmoid shape, and the S shape is because of the change in oxygen affinity to hemoglobin. So it is divided into an upper flat portion and a steeper lower part. The plateau portion is just an indication that a partial pressure of oxygen beyond a certain amount of partial pressure is not going to have any much changes on the saturation of hemoglobin with oxygen. The hemoglobin affinity again is based on certain physiological changes, like when there is a metabolically active tissue, for example, the body wants that more and more oxygen should reach the tissue so that the toxins, that is the carbon dioxide that is being produced and the H plus is being released from there. So there is a rightward shift of the curve in that situation, which is favoring the delivery of oxygen at that tissue. And vice versa happens when there is a leftward shift when the situations are reversed. That is, there is a higher pH, lower CO2 or 2,3 DPG levels have decreased. So after having a rough idea about the oxygen transport, I would like to talk about the toxicity. Toxicity is just patients who have been exposed to high flow oxygen, that is FiO2 more than 60% for at least 24 hours. Especially we see that in mechanically ventilated patients, but can also be, oxygen can also have an adverse effect on patients who are on certain drugs like Briomycin, amiodarone and nitrofurantoin, for example. So oxygen toxicity as such is going to happen at the cellular level. So because of release of these reactive oxygen species, which have a free electron, they're going to initiate inflammation. And if the trauma continues, it can go in for fibrosis. Certain pulmonary effects of oxygen, the adverse effects which we can see is absorption atelectasis. So basically what happens is when we are breathing in air, there is some amount of nitrogen that does not dissolve into the blood as easily as oxygen does. So the nitrogen in turn keeps the alveoli intact. and doesn't allow it to collapse. So when we are replacing this nitrogen, air filled with nitrogen with oxygen, so there is an absorption and lactases that could be harmful for the patient. Then another very common thing that we see in our wards as well, or in the ICUs, is hypercapnia, which develops in patients who are already in chronic hypoxemia, like patients of COPD. So in COPD patients, if there is oversupply of oxygen, like supplemental oxygen is beyond a certain limit, these patients can lose their hypoxic drive, which will ultimately lead to retention of more and more carbon dioxide in their body, which is going to worsen their outcome because of the increase in the work of breathing. And we have to remember that pure oxygen itself has a higher viscosity. So already the patients are having a high work of breathing. So these patients can worsen the outcome in these patients. Now, oxygen, as I've already said, it is going to cause cellular level damage. So there might be interstitial edema development, which further can go on and develop into full-fledged ARDS if we do not cut short the oxygen supply beyond the demand. And especially another example where we see the harmful effects of oxygen in children, newborn infants with hyaline membrane disease. Although they're not mechanically ventilated, but they are given 100% oxygen. So there is a possibility that these infants could go in for bronchopulmonary dysplasia, because they do not have the cellular antioxidant mechanisms to counter this reactive oxygen species. So oxygen has to be treated in a form that it is a drug and it has a therapeutic index. And just my message is, excess of anything is bad. Thank you.
Sorry, just a minute. Wonderfully put. Wonderful information, Dr. Ankita, complete and very, very important. I like what you said, too much of anything is bad, even if it's oxygen. And now we have Dr. Chhabra adding to this, please.
Just a little bit. Dr. Ankita has given a beautiful description of oxygen transport and toxicity. Just want to tell about 4 terms which residents should know how we express oxygenation and adequacy. There is a term PaO2, we all know, arterial blood oxygen, that is partial pressure. Pulse oximetry, that is SpO2, that is what we measure from the point of care device. SaO2 is what we measure in the ABG machine. There can be a difference sometimes in the two. Then there are 2 important terms which are important for tissue. One is content of oxygen, that is CaO2. That depends on saturation PaO2 and hemoglobin, which means that when we treat patients, it's not enough to give oxygen, their hemoglobin also has to be normal. And 4th is DaO2, which is tissue delivery, which depends on cardiac output. So this is very important in conditions like shock, that the cardiac output also has to be normal. So for normal oxygen delivery to tissues, we require normal hemoglobin, we require normal cardiac output, and we require normal lungs. So it's an integration of lungs, blood, and heart.
Wonderful. Thank you so much. I would also like to add something very important that Dr. Ankita spoke about. She said that, high oxygen is bad for certain medicines. So especially I would like to talk about Briomycin, because very often we end up getting Briomycin lung. So basically the thing is that, when oxygen is given to patients of Briomycin toxicity in the lungs, oxygen is going to give rise to eventually oxygen reactive radical species. And this can be actually more pulmotoxic in patients of Briomycin induced injury. And so very clinical important tip is that studies have shown that FiO2 up to 40% is acceptable for patients who've got Briomycin lung injury. However, FiO2 more than 40% is not okay. And then in this case, oxygen will also increase the Briomycin induced lung injury, and it will lead to further interstitial opacities, etc. So I'm sure all of us know, but how do we convert FiO2 into nasal cannula oxygen? Because the thing is that we need to not give more than 40% FiO2, but for some reason, if we don't have a venturi mass, then what do we do? So basically, there's a very important formula 20 plus 4 into liters per minute equals to FiO2. So the thing is that we are breathing normal air, which is 0 liter of extra oxygen. So 4 into 0 is 0, 20 plus 0 is 20. So we all are breathing 20% of air in room air. So this is the formula to convert FiO2 to liters per minute. Please repeating 20 plus 4 into liters per minute into brackets. So the thing is that any FiO2 up to 40% is acceptable. So up to 5 liters of oxygen by nasal cannula for a patient of Briomycin toxicity is fine. If you're going to give more than 5 liters through nasal cannula or through a mask, then there's a high chance of oxygen also affecting the patient. And you may want to give something different, like add some BiPAP earlier so that oxygen is given less. So this was, I think, something that's going to help all of us. After this, let's come to the master herself. So I would like to go to Dr. Jagadamba, the physiologist amongst us. So we all have been talking about VQ mismatch, ventilation perfusion mismatch. So can you please tell us something about ventilation perfusion mismatch, which is important for us?
I think Dr. Chhabra sir has made my job easy by giving clinical entities already. And coming to ventilation perfusion mismatch, the assumption is that all the alveoli are ventilated equally and that blood flow through the alveolar capillaries is the same for each alveolus. However, even normally to some extent, and especially in many lung diseases, some areas of the lungs are well ventilated but have almost no blood flow. Whereas other areas may have excellent blood flow but little or no ventilation. In either of these conditions, gas exchange to the respiratory membrane is seriously impaired. And the person may suffer severe respiratory distress despite both having normal total ventilation or normal total pulmonary blood flow, but within the ventilation and blood flow going to different parts of the lungs. Therefore, highly quantitative concept has been developed to help us understand the respiratory exchange when there is an imbalance between alveolar ventilation and alveolar blood flow. This concept is called ventilation perfusion ratio. So this ratio is the ratio of alveolar ventilation per minute to quantity of blood flow to alveoli per minute. So taking alveolar ventilation as 4 liters per minute and pulmonary blood flow as our cardiac output, which is 5 liters per minute, when the ratio comes, it is around 0.8 to 0.9 the value comes. So at this ratio, the maximum oxygenation occurs. So when the alveolar ventilation is normal for a given alveolus and blood flow is also normal for the same alveolus, the ventilation perfusion is said to be normal. So when the ventilation is zero, yet there is still perfusion of the alveoli, the VA by Q ratio becomes zero. Means it occurs when the rate of blood flow is more than the rate of alveolar ventilation. Since the alveolar ventilation is not enough to provide oxygen, a fraction of blood passes through the pulmonary capillaries without being oxygenated. At the other extremes, when there is adequate ventilation but zero perfusion, the ratio becomes, the VA by Q ratio becomes infinity. So when means the perfusion is zero, so no gas exchange is occurring. Under such circumstances, the composition of alveolar air becomes equal to the humidified air. Whatever we are inspiring, it becomes to that value. So the PO2 becomes 149 millimeters of mercury and PCO2 it becomes, because there is no exchange of gases. At a ratio of either 0 or infinity, there is no exchange of gases through the respiratory membrane of the affected alveoli. So this is the basic concept, and due to gravity, the apical alveoli are underventilated and underperfused, while the basal alveoli are overventilated and overperfused. So this is the concept, and this is what already I think Chhabra sir was discussing the VA by Q mismatch regarding the same. Thank you.
Okay, wonderful. That was quite a complete answer. Anybody wants to add anything, clinical points over here? Yes, sir.
Just one clinical point. The tubercular bacillus that loves oxygen.
Yes.
One of the theories why it affects apices more is because of higher
ventilation.
Yeah, excellent. That was a very important point. We all know this is a theory we all have studied, that best ventilation in the upper lobes. TB bacilli love maximum oxygen and therefore predilection of upper lobes to getting TB. So we had first very, very informative round where we discussed actually the basic physiology. Now let's start application of basic physiology into different things. So first I'd like to come to the Dr. Chhabra. So sir, we'd like to ask you this very important question, that what are the physiological and pathological factors that determine the diffusion capacity of lungs?
Diffusion capacity of lung is a measure of our gas exchange property. Lungs we divide into conducting zone and respiratory zone. So respiratory zone is the region where the alveoli are there and the gas goes across the thin structure which is known as the alveolo-capillary membrane. So there is an epithelium on the alveolar side, there is some bit of interstitium, then there is the capillary endothelium, there is blood, and there is RBC. So the oxygen travels across this. Now it is almost impossible to measure it with precision. What we have is a test called diffusion capacity, which is an approximation only, and it's a very difficult test. So it gives us some idea, and that is used clinically. Now, coming to determinants, it requires that the surface which is available for gas diffusion should be normal. The thickness across which the oxygen has to travel, that should be normal. The pulmonary blood flow should be normal. The hemoglobin should be normal. So when all factors are favorable, that's normal gas exchange. So any pathology which occurs either in the alveolar surface or in the interstitium or in the hemoglobin or in the capillary blood flow, that is going to affect diffusion capacity. So we have got a whole range of diseases beginning from inside outwards, alveolar diseases like emphysema, where the integrity of the alveolar epithelium is lost. So that is one of the major diseases of the airways where diffusion capacity is impaired. And this is in contrast to asthma where the alveoli are not damaged. So that is a test that we can differentiate whether in clinical cases, sometimes we have an issue whether this is COPD or severe asthma. So that is a useful test there. The diffusion capacity is normal in asthma, but reduced in emphysema phenotype of COPD. Then where there is laying down of extra matrix inflammatory cells in different kinds of interstitial lung disease, that imposes a physical barrier. So that is another cause of diffusion impairment. Then any change in hemoglobin, too much of hemoglobin, that is pulmonary hemorrhage, that will cause increased diffusion capacity. Reduced hemoglobin anemia, that will reduce. The changes in pulmonary blood flow, embolism. Then in the very important group of pulmonary hypertension, where there are regional disturbances in pulmonary blood flow because of the remodeling of the small vessels. So there also the gas exchange is impaired. So gas exchange is impaired in all of these conditions, whether this could be in the alveoli, in the interstitium, or in the pulmonary vasculature. Besides that, there are certain factors which we correct when we do a diffusion capacity test. One is hemoglobin, because hemoglobin affects DLCO. So there is a correction factor which is applied. You know, in the report which we get in a diffusion capacity report, there is an uncorrected diffusion capacity and there is a corrected diffusion. So that corrected one includes this correction because we express diffusion capacity as if the person's hemoglobin is normal to remove the effect of anemia. So that is first correction. Second correction is for carboxyhemoglobin. Although we assume that there is no carboxyhemoglobin, but it is there in the atmosphere and that can reduce hemoglobin. So that is corrected. Then we make an altitude correction because with altitude, the diffusion capacity increases. So in measurement, routinely we make 3 corrections for hemoglobin, for carboxyhemoglobin, and for altitude. So these are physiological factors which are to be corrected. Besides this, there are factors like the person should not smoke before he comes for the test. He should not take a heavy meal before he comes for the test. He should not do any exercise because these factors will physiologically affect diffusion capacity. So these are some of the physiological factors and the pathological factors that I mentioned earlier. So as in fact, in some of the diseases like pulmonary hypertension, it may be the sole test which is abnormal. All other lung function tests are normal. Then there are early interstitial lung diseases where again diffusion capacity may be the only test which is abnormal. So it is a difficult test, not easily available, but standardization protocols are available and we have our own prediction equations also for diffusion capacity. So diffusion capacity is a very, very useful test of the integrity of that area, that is the respiratory zone of the lungs.
Wonderful. That was a fantastic answer. So 2 important points. If the diffusion is more than 100%, then please suspect pulmonary alveolar hemorrhage in a patient because this is the only condition where diffusion is going to go up. So that's one thing. And the second thing is what I really liked what Dr. Chhabra said was correction for anemia. So I don't know how many of y'all really do it, But for my patients, it's a mandatory that they need a recent hemoglobin, which is within 4 weeks. And that hemoglobin is entered by the PFT technician into the machine. And then they are made to undergo a diffusion test. Because if your hemoglobin is less than 12, then falsely the machine will be giving a wrong DLCO, which is going to be reduced. And in some patients where you want to know whether nintedanib is working or not, or pirfenidone is working or not, etc., it can actually make a big decision about your antifibrotics getting affected. So please make it a point that your patient is not smoked before for the carboxy hemoglobin levels, and the hemoglobin is put in by your technician, the corrected hemoglobin, so that you don't get a falsely reduced DLCO because the hemoglobin was not given to be corrected. Thank you, Dr. Chhabra, with these very important points. Now, I'd like to once again come to Dr. Jagadamba. So, Dr. Chhabra was talking about diffusion. I would like to ask you, please elaborate on physiology of airway resistance.
Yeah. Airway resistance, actually, in asthma and all, what we have till now, it is like obstructive lung disease. Why during expiration it becomes very difficult to expire? This concept comes there. It is the resistance caused by the friction of gas molecules between themselves and the walls of the airways, and the normal value ranges from 1 to 3 centimeter of water per liter per second. So normally when we talk, we have two types of flow, laminar flow and the turbulent flow. So here we apply the Hagen-Poiseuille's law when airflow is laminar, that is when air molecules move smoothly in the same direction. We apply this Hagen-Poiseuille's law, which states that the resistance of a tube is proportional to the viscosity of the gas and length of the tube, but inversely proportional to the fourth power of the radius. So this is based on the Hagen-Poiseuille's law. So coming to the factors affecting airway resistance, rate of gas flow, it affects the major. Means when the rate of gas flow is more, the resistance will be more. So because, and this rate of gas flow is highest in the intermediate size bronchi, as they have highest cross-sectional area. So the highest resistance to flow across in the part of tracheobronchial tree. Coming to airway radius, it is the most powerful determinant of resistance. Smaller the radius of the airway, greater is the resistance. That is, resistance is indirectly proportional to the r to the power of radius, r to the power of 4 radius. So in other words, if radius decreases by half, the resistance increases by 16 times. So if the radius decreases by half, it increases by 16 times. The key aspect of equation is that airflow is extraordinarily sensitive to changes in airway radius. The 4th power dependence of resistance on radius means that 10% decrease in radius causes 52% in increase in resistance. That is, there is 34% decrease in airflow occurs. So airway radius increases when lungs expand, that is during inspiration, and decreases when lungs contract during expiration. Therefore, airway resistance is high during expiration as compared to inspiration. Because of this reason, in bronchial asthma patients where bronchoconstriction develops, inspiration is possible, but there is extreme difficulty in expiration. So this is the main reason. So, but length of the airway, as the tube remains constant, here the length of the airway, one more factor, doesn't affect that much. But type of airflow, if the airflow is turbulent, that time the resistance increases. One more factor is tone of the bronchial smooth muscle, which is dependent on the which is supplied by the parasympathetic and sympathetic nervous system. The parasympathetic nervous system stimulation produces relaxation of bronchial smooth muscle via the stimulation of beta 2 receptors, which increases the airway diameter and which decreases the resistance, which further increases the airflow. So it is adrenergic agonist. Parasympathetic stimulation produces constriction of the bronchial smooth muscle, reduces the diameter, increases the resistance, and decreases the airflow. This is the concept in sympathetic and parasympathetic nervous system where we give the medication. And chemical stimulants, dust, toxins, all these things, they cause reflex constriction of the bronchiole. And viscosity and density of the inspired gas also, they have an influence. That's why viscosity and density decreases the airflow, which increases the resistance. That's why in scuba divers and all, they give oxygen helium where the density and viscosity is less. So these are some of the concepts regarding airway levels.
Okay, that was fantastic, very, very interesting. I'd forgotten most of these things, and I'm very, very happy to know all these concepts back again. It actually explains why patients of emphysema or asthma end up having air trapping at the end of expiration, because expiration, the resistance is always more. So inspiration will still happen, but expiration will not take place. And that is the reason often these people have hyperinflation in the chest X-ray. I feel Dr. Chhabra is very keen to say something before he could raise his hand. I know it.
Yeah.
Would you like to add something?
Well, so basically, I'm a clinical person. So what Dr. Jagadamba has told about the basic physiology, I'll come to the clinical aspect.
Yes, sir.
The airways are peripheral and central. The peripheral airways can have a substantial increase in resistance without causing any problem for the patient. So that is called the silent zone of the lungs. And that is where COPD begins. So that's why the new concept, which is now encapsulated in Goal 2023, that COPD begins much earlier than when it is clinically manifest. So we are having concept like pre-COPD and early COPD. So that region is where we do not have any reliable tests to pick up that disease. So that's a silent zone of the lungs where the resistance increases, but it is not clinically manifest.
Okay, sir.
Yeah, wonderful. And even I'd like to just add this, about the viscosity and particles of the gases. So we know that helium is much lesser than oxygen. And that is the reason often when a patient comes with vocal cord dysfunction, we actually give them helium-oxygen mixture. And very often the breathing gets okay and the vocal cords which are adducted together sometimes do get abducted. So very important points, we have forgotten the basics. We remember the applications. It's good to remember our physiology back again. Now I'd like to come to Dr. Anu, because her passion is sleep, and so is my passion too. I'd like to ask Dr. Anu please tell us about the respiration in sleep and in different sleep states, in short.
Thank you for saying in short, because I can continue for 45 minutes on this. So I'm going to quickly give just a few points of what happens, physiology of sleep as we call it. So sleep state is associated with lots of changes in respiratory physiology, including the ventilatory response to hypoxia, to hypercapnia, the upper airway muscle tone, the intercostal muscles, the tidal volume, the minute ventilation, and you name it. And sleep actually is a state which occurs because wakefulness stimulus is lost, right? So, so basically the stimulus for respiration, wakefulness stimulus is a very important pathway. Other is metabolic. So metabolic demand is the only primary determinant of minute ventilation in sleep. And it starts with this circadian rhythm where there's a decline in body temperature. And that actually causes, the arousal responses from the cortex and the brainstem to be inhibited. And that's when GABA and galanin are secreted and sleep is actually induced, right? So now, having said that, in REM sleep, there is more sympathetic tone, while the non-REM sleep, dominantly you have a parasympathetic tone. So therefore, blood pressure and heart rate may be increased in REM sleep, while blood pressure and heart rate are reduced in non-REM sleep. Now, minute ventilation definitely falls with sleep onset in response to the lower metabolism that is there in the body. And there is decreased chemosensitivity to oxygen and carbon dioxide. So the worst is in stage 3 of sleep, where the minute ventilation really reduces and end tidal CO2 actually goes up by 1 to 2 torrs of mouth. So tidal volume is further reduced in REM sleep, even lower to non-REM sleep. So then there is a linear increase in ventilatory response to this PCO2, and this persists, but the slope is definitely reduced compared to an awake. So this might actually lead to hypoxia, hypercapnia, and might trigger arousals. Now, both the hypercapnic ventilatory response and the hypoxemic ventilatory response are reduced in decline in both in non-REM and in REM sleep. And the reason is not known. It's probably due to decline in the chemoresponsiveness, probably because of increased upper airway resistance, maybe leptin-induced pathology pathways in REM sleep. So arousal during sleep, and arousals occur, it's an important response because both the hypoxemia and hypercapnia arousal responses are again reduced in non-REM sleep compared to REM sleep. And inspiratory resistance or airway occlusion increases arousal during non-REM and REM sleep stages, but more in REM sleep. Now, coming to the upper airway muscle tone, that is also reduced in sleep, and it could lead to collapse of the airways, especially genioglottal muscle activity, and if the lumen is smaller. Postural changes in sleep also affect mechanisms of breathing, because both the functional residual capacity and the total lung capacity are reduced in the supine position. And if there's an anatomic obstruction due to whatever, parapharyngeal fat or retroglossal narrowing of the upper airways, then there's vascular congestion in the airways. All this causes increase in airway resistance in sleep. In non-REM sleep, the intercostal activity is increased, and it contributes to the chest wall expansion. While in REM sleep, we know the skeletal muscle atonia and respiration is impaired, and ventilation occurs only with the diaphragm. So can you imagine a state where in REM sleep, there can be a paradoxical collapse of the chest, because the chest wall compliance is increased with decrease in the intercostal tone. So there's a paradoxical movement of the chest wall. The load compensations are also reduced in sleep, both elastic loading and resistance loading. So ultimately what happens in sleep compared to wakefulness is that there is a mild hypoventilation that occurs in everybody, in normal subjects. And obviously in patients who have any form of airways obstruction, interstitial lung disease, sleep disordered breathings, neuromuscular disease, this is going to get augmented.
That was wonderful, very, very clinical. Found it extremely interesting. And therefore, this, we often have COPD related hypoventilation where the PO2 goes down. It's not that they have sleep apnea or something. And if they are not retaining carbon dioxide, then we often just end up giving them oxygen, because this is what is really happening in sleep, like Dr. Anuradha told us. Thank you very much. After that, now I'd like to come to Dr. Amit. So, Dr. Amit, please tell us about breathing exercises in cardiac diseases.
Yes, sure, ma'am. So what breathing exercises in cardiac disease? First, we have to just question why the breathing exercises, what happens actually in cardiac disease. So basically, we have to target in cardiac disease, we have to think about what are the risk factors, metabolic risk factors, which are affecting the cardiac outcome, the autonomic nervous system, which affects the heart rate variability, which is an important mortality marker in cardiac patients. In such patients, because cardiac patients are usually chronic patient, it is a chronic inflammatory state. So chronic inflammation is one more problem we have. We have another problem, which is neurohormonal activation, because of which the remodeling process occurs and worsening of the cardiac symptoms happens. And ultimately, all of this decreases the immune system. So we have different medications. We follow them like verdict of God, the guideline directed medical therapy. But what if everything is coming under one thing? That is by doing good physiotherapy or giving good breathing exercises to the patient. It is important because it is cheap. Actually, it is free of cost. It is very motivating. And usually patient, once taught some simple breathing exercises, they usually are very well compliant to it. So what are the breathing exercises for our cardiac patients are? Usually our cardiac patients, even for post-heart attack or patients with heart failure or patients with post-bypass surgery, to improve the compliance is very, very important. And to motivate them is another thing, because once these patients are having chronic diseases, usually the motivation towards life is less. So breathing exercises helps on different mechanisms. So I'll just show you one slide share and I'll explain simultaneously. I'll share my screen again. So this is the parameters which I'm talking about. Once you ask the patient to do breathing exercises, we can ask the patient to do different kind of simple breathing exercises. One thing is very important in cardiac patients is we have to avoid those kind of exercises which are involving breath holding. Breath holding is not good for a cardiac patient, because when you hold the breath, it actually may induce a Valsalva in some patients because they hold the breath for a longer period of time, which can affect the autonomic nervous system, increase the sympathetic flow and decrease the parasympathetic flow, and causes detrimental effects to the cardiac outcome. So avoiding those exercises, the simple breathing exercises like Anulom Vilom, or we advise the patients, especially who are in the cardiac rehabilitation, we ask them to take deep breathing exercises. Deep breathing exercises, usually we ask the patient for diaphragmatic, because diaphragm is one of the muscle of respiration. So in order, the patient should use less of the accessory muscle and use more of the normal respiratory muscles. Diaphragmatic strengthening is very, very important. So we ask the patient to take deep breath from the stomach. We ask them to hold both the hands towards the stomach, take deep breath in and release the breath out. Take deep breath in and release the breath out. We ask the patient to do it slowly and such slow that we ask the patient to do, like, for example, to the count of 3 for inspiration, to the count of 6 for expiration, because expiration is what, the prolonged expiration is what will achieve the deep breathing exercises job fully done. Second, we ask the patient to do is, we ask them to do pursed lip breathing. Pursed lip breathing is again like inducing an autopsy. So inspiration is normal, like take for 3 to 4 seconds and expirate it slowly by pursed lips, so that there is an autopsy which recruits more of the alveoli, improves the peripheral bronchioles, and improve the tidal volume for the patient, which ultimately will decrease the mismatch between ventilation and perfusion. We also ask the patient to do some of the humming exercises, like how it is done in different kind of yogas, where we ask them to close the ear as well as close the eyes and hum loudly. This humming exercises, again, it brings calmness towards the entire structure. It decreases the sympathetic flow, improves the parasympathetic flow, and it will ultimately improve the outcome. Most importantly, we have seen that once we put a patient on good breathing exercises, 2 parameters are very important, which are shown to be actually improving. One is systemic blood pressure. The systolic blood pressure comes down importantly for around 8 to 10 mmHg, which is better than giving 2 of the antihypertensive medications sometimes, less potent medications. As well as we have seen that patients who are doing breathing exercises regularly, there is a decrease in the waist circumference, which decreases the metabolic risk factors for the cardiac patients.
Wow. Wow, this was really very interesting, because I never knew that for cardiac patients also breathing exercises would help so much.
Okay. They work in sync, ma'am, cardiopulmonary.
Yeah, that's very, very interesting. I just want to put in a clinical point. At least this is what I believe in. Often my patients with, really bad ILD or very bad COPD, or, patients with cystic lung disease say that, oh, I'm doing yoga and I'm doing breathing exercise and I'm doing pranayama and I'm feeling so good. And so only thing I tell them, okay, do what you want, don't do Kapalbhati, because I'm always worried that, with the post expiration, which is given over there, there's a small chance of patients developing a pneumothorax. So that's something which is scary. So I think we should tell them not to do Kapalbhati, other exercises, of course, and not to make them breath hold the cardiac patients. I thought that was a very important point I wasn't really aware of. So thank you. This was great to know. Okay, now I'd like to come to Dr. Ankita. So Dr. Ankita, I want to ask you a very interesting question, which is very, very clinical. So can you please tell us about physiology of different breath sounds? We keep on auscultating our patients. So please tell us how do they get originated, and what is their application towards a diagnosis?
Okay, ma'am. Ma'am, the normal breath sounds, they are generated as the air enters the larger airways. So there is this turbulence that is created. So the turbulence generates high-pitched, loud breath sounds of 200 to 2000 hertz. Now, as and when it is being transmitted through the lungs, it dampens out the higher frequency sounds, and only soft-pitched sounds that are between 200 to 400 hertz are generally conducted. So the normal breath sounds which we hear range from vesicular breath sounds, which has a soft rustling and a low pitch character. It has no pause between the inspiratory and expiratory sounds, and it is mostly heard all over the chest field. Then there is another normal breath sound which we hear is a tracheobronchial or a tracheal sound, which is generally heard over the larger airways, the trachea and the larynx. And there is usually a pause between the inspiration and expiration, and they are of equal duration. Another intermediate sound that is heard, which is called as a bronchovesicular sound, that is generally heard over the upper sternum, the T3, T4 vertebra in between the scapula. So apart from these sounds, which are the normal sounds, even these sounds heard at abnormal sites or with varying intensity or pitch would point towards an abnormal breath sound. So we can talk about when there is a decrease in intensity of the breath sounds. The normal breath sounds it could be a defect in the generation of the breath sounds or a conduction. So sound generation defects could mean when the patient is breathing very quietly, physiologically speaking. Pathology wise, it could be a pleurisy. The patient might be in some kind of pain because of which he's not able to take deep breaths. Or there is a respiratory muscle paralysis that would decrease the generation of sound and decrease the intensity. If there is a conduction defect like a pleural pathology, like a massive pleural effusion or an obese patient or a pneumothorax, there can be a conduction problem, and because of which the intensity might decrease. The increased intensity of breath sounds, we hear it physiologically, patient, an anxious patient breathing loudly, and pathologically we hear it in patients who are having compensatory emphysema, especially tuberculosis patients, post-tuberculosis sequelae patients who have compensatory emphysema. They can have an increased intensity of breath sounds. There is something called as bronchial breath sounds, as we all know. Bronchial breath sounds are actually normal breath sounds, but if they are heard at sites other than the sites which I've mentioned, they are considered to be abnormal. And based on the type of the sound that we are hearing, we have like 3 types of bronchial breath sounds, mainly the tubular bronchial breath sounds, which we most often come across during consolidation. So in consolidation, the lung basically goes for hepatization. So because of which the sound which is coming from the larger airways is directly getting conducted. So there is a louder quality to the sound. Or we can hear it in pulmonary infarction as well. When we talk about cavernous nature of bronchial breath sounds, it is generally heard in a lung cavity or an open pneumothorax, or when there is apical fibrosis, which has led the trachea to shift towards that side. So the tracheal sounds get conducted and we can hear a cavernous bronchial breath sounds. Amphoric breath sounds, which is having a metallic tinge to it. It is heard in cases of large smooth wall cavity or a pneumothorax, which is having communication with the bronchus. These were the abnormal breath sounds. We have certain added breath sounds as well. Most commonly encountered are the wheeze, the crepitations, and the pleural frictional rubs. Wheeze per se are actually musical sounds, and they're generally generated because of airflow, because of movement of the air through narrowed airways. And they can be monophonic or they can be polyphonic. The monophonic means they have a same single tone of the single pitch that they are being generated. Stridor is one such example of a monophonic wheeze, which is heard in cases of upper airway obstructions like laryngeal, foreign body, or tumor. We have polyphonic wheeze, which we commonly come across in asthmatic patients or COPD patients, where each sound is of a different pitch, and it is basically heard during the expiratory phase. Moving on to crepitations. Crepitations, earlier it was thought that crepitations were generated because of the movement of air through secretions. But now we have this new concept that it is an opening snap. It is actually the equalization of pressure because of the flow of air through the airways. So rather than an alveolar problem, it is more attributed to an airway cause of generation of sound. And again, depending on the phase of respiration, it can be inspiratory or late inspiratory or expiratory. Expiratory are generally in obstructive, severe obstructive diseases. We can have both, a wheeze as well as a crepitation. And inspiratory creps, early inspiratory creps, especially in cases of your ILDs, like Velcro creps, etc., we can find in the ILDs especially. Finally, coming to the pleural rub. Pleural rub is because of rubbing of the 2 inflamed pleura against each other. They have a very leathery characteristic and they're not very continuous. They're a jerky sound and they're a loud sound. And we can best appreciate them in the lower part of the axilla. And these sounds will not be altered by coughing. Thank you, ma'am.
Wonderful. Yes, Dr. Chhabra.
So one addition to this wonderful revision of lung sounds, crepitations are also called crackles. That is one terminology. The other thing about the subclassifying of bronchial breath sounds, I remember that when I did my MD, so old timers, previous generation, those examiners were very fond of cavernous breath sounds, amphoric and tubular breath sounds. However, when the physics of the sounds has been applied, so the specificity for different lung conditions is lost by these descriptions. So they are not very distinctive. So I don't insist that you tell that this is cavernous breath sound or amphoric. If you tell that it's bronchial breath sound, the resident will pass. The distinction between bronchial and vesicular is important. cavernous, amphoric, tubular, there can be, between individual differences because they are overlaps. So specificity is not that much. So that pitfall must be recognized there.
Wonderful. Yeah, I'll also just like to add to this that, yes, of course, now with X-rays and CT scans so much available, basically it may not be very important to identify these breath sounds, but just a common tip, for a very simple tip which has helped me. So we know bronchial breathing are of two types. It's tubular, amphoric, and cavernous. So if it's high-pitched bronchial breathing, so basically when the inspiration, there is gap, and then expiration is as long as inspiration. And if it's high pitched, then it's either tubular or amphoric bronchial breathing. Then when you identify it's high pitched bronchial breathing, you make the patient cough with the stethoscope and keeping the stethoscope in that area. And if you hear a metallic tinge to the cough, then it's amphoric breathing. And if you don't hear a metallic tinge, then it's tubular bronchial breathing. If the bronchial breathing is low pitched, then it's cavernous. So actually identifying is also easy. If we keep on auscultating more and more patients, go just to a TV board, keep on auscultating them, and you'll know exactly what they sound like. So may not be very important clinically now, but I feel it's always good to be a good clinical person who is.
Can I add one?
Sure, ma'am, please.
Actually, we are from medical college. So first years we are teaching. Basically, the respiratory system, when we teach them, the differences between vesicular, bronchial, everything. And we have skill lab also, where the simulations we are giving all these respiratory sounds, various types of respiratory. We make them hear all those things. And we tell them to come back. When you see a patient, if you're not following it up, come to the skill lab, simulated, this one is there. You can hear those sounds and try to remember, otherwise it becomes difficult for them. So this is the basics we teach them in first MBBS in the simulated labs also.
That's perfect teaching. I think it's wonderful. And if we are not lucky enough to be belonging to a college in Kolar, then we can actually go on the internet and you can just type, breathing YouTube video and you'll be able to hear it.
Yes, yes. That is also.
I'm very happy to.
Very relevant,
Yes, sure. I have a very important announcement to make. We already have 938 logins for our webinar. I was wondering actually if anybody will log in or not, but like almost 1,000 people are there, which is fantastic. And of course, with the star-studded faculty, these wonderful panelists, it's not really a surprise.
And the moderator too.
With this, now let's start the third round of our questions. There are just so many questions in chat box, so I'm going to keep on asking them also side by side. So we come to Dr. Chhabra. What aspect of lung physiology does spirometry provide information on?
Spirometry is a wonderful test, and it's the oldest lung function test that we have got. When Hutchinson described this, he described it volume measurement only, vital capacity. Then Robert Hyatt came up with the flow volume group, and that is what changed entirely the range of information that we get from spirometry. So spirometry has an excellent reproducibility, repeatability, and has been clinically validated so extensively that every research in any lung disease uses spirometry as the outcome parameter. Any paper you pick up, any drug trial in COPD, ILD, outcome parameter is always that. So that is the wonderful test that we have. And the amazing part is that it is done with a maneuver which is not physiological. Normally we don't breathe out with forceful expiration, but it provides useful information. So the information that it provides is about lung mechanics. Now that lung mechanics alteration can be because of airway diseases, or can be because of parenchymal disease, pleural disease, or chest wall disease. So we have a very simple algorithm based on just two parameters, FEU1 and FEC, and their ratio. And we can describe 4 kinds of patterns in the lung besides upper airway involvements where the loops changed. So it provides information within the lung about obstructive conditions, then diseases which cause small volumes, the restrictive patterns. Although we should not use the term restrictive on spirometry, it needs confirmation by TLC measurements. Then there are mixed kind of patterns where they are both obstructive disease plus a parenchymal or a pleural or a chest wall disease. Then the patterns of upper airways obstruction, whether it's a variable inspiratory, variable expiratory, or a fixed obstruction. So it provides information about the upper airway mechanics also. So all in all, lung mechanics alterations anywhere from upper respiratory tract to lower respiratory tract is picked up by spirometry very well.
Wonderful, sir. This was very elaborate, but a short answer. I really liked it. I would request everybody to give short answers because we have so many questions to cover. I'd like to come to Dr. Jagadamba. Please tell us about the physiology of surfactant and ARDS. We keep on facing this all the time and we are just so stuck about how to ventilate our patients. So please elaborate.
Pulmonary surfactant is a mixture of lipids, mainly dipalmityl phosphatidyl-choline and apoproteins. Term surfactant means a surface active agent because surfactants have both a hydrophilic region strongly attracted to water and a hydrophobic region strongly repelled by water. They localize to the surface of an air-water interface. Type 2 alveolar cells, that is the cuboidal epithelial cells, synthesize and secrete the pulmonary surfactant. So in this, the composition, lipids make up to 90% of the surfactant and are responsible for the surface active properties. About half of the lipid is dipalmityl phosphatidyl-choline. Proteins account for remaining 10% of the pulmonary surfactant. Plasma proteins, mainly albumin, and secretory IgA make up about half of the protein, and 4 apoproteins, that is SPA, SPB, SPC, and SPD make up the rest. SPA and SPD are water soluble and have collagen-like domains. Both contribute to innate immunity by acting as opsonins to coat bacteria and viruses, thereby promoting phagocytosis by macrophages resident in the alveoli. The 2 hydrophobic apoproteins, SPB and SPC, are intrinsic membrane proteins that greatly increase the rate at which surfactant enters the air-water interface and then spread as surface film. So these 2 proteins, they bring about this. So the hereditary absence of SPB leads to respiratory distress. So this pulmonary surfactant reduces the surface tension and increases the compliance. So it has got mainly the surfactant present at the alveolar air-water interface has 3 major effects. Because surfactant reduces surface tension, it increases the compliance, making it far easier to inflate the lungs. By reducing surface tension, surfactant minimizes fluid accumulation in the alveolus. In the absence of surfactant, the large surface tension of the liquid layer between the air and the alveolar type 1 cells would cause the air bubble to collapse, drawing fluid into the alveolar space from the interstitium. The net effect would be to increase the thickness of the liquid layer, thereby impairing the gas diffusion. Surfactant helps keep the alveolar size relatively uniform during the respiratory cycle. It decreases the work of breathing, and IgA, which is present in the surfactant, provides the innate immunity. Coming to the pathophysiology of ARDS, influx of proteinaceous plasma fluid, erythrocytes, and inflammatory cells into the interstitium destroyed by the surfactant, and type 1, type 2 pneumocytes increases the alveolar surface tension, thus producing the alveolar collapse. This is the basic thing. Though ARDS is a vast thing, we can't cover it up. So mainly the because of the surfactant, it tries to reduce the surface tension at the liquid alveolar interface. Thank you.
Yeah, wonderful. So now I'd like to come to Dr. Ankita. So ARDS, we just spoke about. Let's talk about its other counterpart. So what is the physiology behind pulmonary edema? Now that we know what is the physiology behind ARDS.
Ma'am, basically the interstitium and capillary endothelium, they're being separated by this basement membrane, and based on the permeability of the capillary endothelial membrane and the basement membrane, there is a gradient that is established, and that is determined by the Starling's equation, that is difference of the hydrostatic versus the oncotic pressure across both the membrane, across the membrane. So when normally this capillary hydrostatic pressure usually exceeds the hydrostatic pressure of the interstitium, which directs the direction of the flow is determined accordingly, and the fluid enters into the interstitium from where it is drained into the lymphatics and removed. Abnormal accumulation of this fluid in the extravascular spaces of the lung is going to lead to pulmonary edema. There are multiple mechanisms that can lead to this pathological accumulation, but the most striking or important one would be the increase in capillary hydrostatic pressure, which we generally seen in the cardiac ailments like mitral stenosis or myocardial infarction or a case of fluid overload. Other causes which can lead to accumulation of fluid is increase in the capillary permeability. That is, in cases of exposure to certain toxins, or in case of sepsis, or as I said, oxygen toxicity, or ARDS per se. Or if there is a reduced lymphatic drainage, the lymphatic drainage could have obstruction or injury to the lymphatic channels. That could also lead to accumulation of fluid in the interstitium. There can be a decrease in the interstitial pressure, that is because of rapid correction of pleural effusion or because of pneumothorax, or a decrease in oncotic pressure like hypoalbuminemia or overtransfusion. That also can lead to abnormal accumulation of fluid in the interstitium. Hypoxic vasoconstriction, which happens in high altitude, which leads to high altitude pulmonary edema. Again, one of the causes responsible for development of this. But again, there are certain unknown mechanisms involved. For example, in case of patients using heroin, or neurogenic causes of development of pulmonary edema, with the causes not yet determined. Thank you, ma'am.
Yeah, wonderful. This was very, very important. You summed up everything. So I'd like to come to Dr. Amit. We spoke about pulmonary edema, which can happen because of left heart failure, and we have to use less fluids, etc. So now we are pulmonologists. We want to talk basically about right heart failure. So you please tell me that if a patient has cor pulmonale and is presented with right heart failure, and if the LV function is normal, what would be the fluid management of this patient?
So it has got two aspects to it. One is that the patient has got right ventricular dysfunction, and he has got left ventricular function, which is apparently normal.
Along with normal diastolic function, normal valves, everything. Only the right heart. Patient is in right heart failure.
Okay, fine.
And what is the fluid management you recommend for this patient?
So fluid management is little tricky, because as we know that right heart failure patients are usually fluid overloaded, and they present with right heart failure symptoms, which is showing obviously a lot of fluids in the form of ascites and pedal edema and raised JVP. However, fluid is the one thing which is going to make a difference in the outcome. So the problem here in right heart failure, we have to first ask is, what is the problem with the right heart? Whether there is infarction of the right ventricle, in which case we have to go for the improvement in the ischemic parameters, even improve the.
We are talking only about pulmonary conditions, no heart condition.
Yeah, ma'am. But these things go hand in hand. And second thing is about pulmonary embolism. So if a patient has got pulmonary embolism, in such cases, fluids have to be used very, very judiciously. If at all patient presents with severe hypotension, a very small dose of fluid may be sufficient, because the more we give fluid, because there is no forward output, it is going to cause more and more increase in the volume in the right ventricle. And because right and left ventricle work in synchrony, it is going to cause more and more decrease in the left ventricular cardiac output. So fluid should be used very judiciously. In fact, not used in most of the cases when the patient presents with pulmonary embolism, where we have to treat with thrombolysis. Third is patients who have got pulmonary artery hypertension. Now here, when the patients have got pulmonary artery hypertension, we have to give fluids, because once we give fluid, they are going to improve the preload for the left ventricle and ultimately improving the cardiac output. Usually the fluid of choice in such cases is normal saline, what we commonly use, because many a time these patients, because of their chronic congestion, there may be increase in the vascular, in the glomerular hypertension due to venous hypertension of the glomerulus. The patients usually have borderline kidney issues also. So we can use ringolactate, but we have to be a little careful about the potassium levels in such cases. Dextrose we don't use commonly. What commonly we use is normal saline, and once the patient has showing a tendency towards going into hypernatremia, that means sodium level starting to go after 140, we switch it to half NS. The target here, what we keep is around keeping the CVP levels around 10 to 12. But fluid alone is not going to make the difference. It has to be supported by using appropriate inotropes, which are going to improve the right ventricular function. That is inotropes like dobutamine, levosimendan, milrinone. As well as if the patient has got severe pulmonary artery hypertension, decreasing the pulmonary hypertension by giving vasodilators like.
All right. Okay, fine. So okay, fine. Anybody wants to add anything? Because I would like to add something thereafter. Dr. Chhabra, anybody wants to say something?
See, the issue of giving fluids in cor pulmonale would arise only when you're dealing with septic shock. Otherwise, there is no issue of giving fluid restriction is the rule in copper panel.
So actually, I purposely have asked this question. So I want to basically tell everybody, if you read Braunwald, which is like actually the mecca of cardiology, which I have read during my residency, and even when we did our cardiology term, I just want all our friends to know that when we have patients of right heart failure because of straight lung causes like either COPD or ILD who have cor pulmonale who come in right heart failure, honestly speaking, fluid restriction is not required at all. Very often we see fluid restriction of 1.2 liters, salt restricted diet, IV Lasix, etc. So what I want to basically tell you is that this is the edema that we are seeing in right heart failure is cosmetic. You are seeing edema in the feet, but it's not going to really make any difference. But in fact, these people have such severe pulmonary vasoconstriction because of hypoxia, hypercapnia, and polycythemia. As a result of that, no blood from the right ventricle is entering the pulmonary circulation, and as a result of that, you're in right heart failure, everything is going back. So in fact, when you give fluids to these people, it actually works as a driving pressure. And even if there's severe pulmonary hypertension, the fluid actually passes into the pulmonary circulation, and it actually brings about better oxygenation of the patient. Meantime, you're trying to correct the primary pathology by treating the infection, treating the exacerbation by putting the patient on NIV or on ventilation. So I want to actually tell you that a left heart failure patient, while you may want to fluid restrict, you may want to give Lasix round the clock, etc. In a right heart failure because of COPD, ILD, we don't necessarily need to do this.
Fluid requirement.
Yeah, so I want to basically just make a point that we don't need to do this. Giving Lasix is going to unnecessarily cause hypokalemia. These people already have hypokalemia because of the salbutamol nebulizations, because of steroids, etc. So this is a very important point I want the residents to know.
In fact, the cor pulmonale also have a reduced cardiac output for two reasons. One, there is an interdependence of the two ventricles also, and very often the interventricular septum shifts towards the left ventricle, reducing its cavity.
Exactly.
So cardiac output is already reduced in these patients.
Correct. So the thing is, if we don't improve pulmonary circulation by allowing the fluid to enter the pulmonary circulation, the interventricular septum from the right side will further push on the left. So very often this would basically help. Okay, great. Yes.
Just a couple of points. One is, as sir absolutely correctly mentioned, that the interventricular dependence plays a major role. But in a patient who has got just strictly right heart failure, unless we give fluid, it is not going to improve the cardiac output. So giving fluids along with adjacent inotropy or vasodilators for pulmonary circulation is the thing which is going to improve the outcome, except for patients with pulmonary embolism. Patients with massive pulmonary embolism, it is just like giving fluids when a patient comes with cardiac tamponade. Very minimal, if at all needed, just for initial support, not more than that.
Point well taken, but I agree with this that, if the right heart failure, then while you are correcting the cause of right heart acute exacerbation, like giving oxygen, giving antibiotics, correcting ventilation, fluids are actually required if the left heart is fine. And this is an important point I would like everybody to know. Okay, just moving ahead, coming to Dr. Anu. Sleep is a passion, and I really like to listen to all the techniques and all the tips that she tells us. So, in short, can you please tell us about the physiology of sleep apnea? What goes wrong in sleep apnea?
Really very short. And I'll talk of obstructive sleep apnea, where we know that the upper part of the airways collapsed at night during sleep, causing hypoxemia, hypercapnia, leading to sympathetic activation and arousals, right? So in the pathophysiology, who gets sleep apnea? There is definitely a role of upper airway anatomy. So some people have smaller upper airways, which is seen even in wakefulness when they're awake. And when you do MRIs and you look at the pharyngeal, especially the area behind the heart palate going up to the larynx. And also evidence, if you do the peak crit pressure, you'll find that the peak crit pressure is elevated in such people. And if these people have, a large tongue, parapharyngeal fat pads, and soft tissue palatal volume is increased, these people have a propensity to cause upper airway collapse and cause sleep apnea. Upper airway dilator muscle activity, as we know, all the wakefulness stimuli, which has the hormones which include serotonin, orexin, acetylcholine, NORAD, all these lose their activity in sleep. And in some patients, the genioglottal muscle is affected because of that. And that's why the upper airway tends to collapse. They're not dilated because of the genioglottal, and such people tend to end up with sleep apnea. Thirdly is the arousal threshold. Ultimately, arousal is a very, very important response, right? And only if you arouse, then you can balance the PO2s and the PCO2s. So OSA patients definitely have an impaired arousal response to airway occlusion. And so they need more negative pressure. They have a higher arousal threshold. 30% of OSAs have a low arousal threshold. What happens if the arousal threshold is really low? Their ventilation is still not stabilized. And, they go back into repeated cycles of breathings, which are suboptimal. So such patients, you've got to be careful, identify if they have a low arousal threshold, because this drug, Zopiclone, I have not really used it, elevates the arousal threshold in these patients. And last but not least is the ventilatory control stability in OSA patients, and that's the loop gain. Basically, we know what the loop gain is. It refers to the stability of the respiratory system and how responsive it is to disturbances in breathing. Controller gain and plant gain. Chemoresponsiveness of the system to hypoxia and hypercapnia is the controller, while the plant gain is the primary efficiency of carbon dioxide excretion in the lung. So if there's a high loop gain, then there's a very unstable response, and this is predominantly seen in OSA patients. And last but not least, lung volumes do play a small role. So people who have larger lung volumes, for whatever reason, and people who have lesser lung volumes. So if they have lesser lung volumes, and in non-REM sleep, the tidal volume is further reduced because of physiology of sleep, then they tend to collapse the airways, and it can cause sleep apnea. Short and sweet.
Wonderful. Very elaborate, but short. Thank you very, very much. We still have 9:30 logins. Still, people are still listening. I'm so happy. There are just so many questions which have come up. I just feel that quickly, one line answers or shortest possible answers by everybody so that we can cover up more. I'd like to ask Dr. Chhabra, what are the different techniques of measuring static lung volumes and what are the clinical applications?
We have got broadly two techniques. One utilizes gas dilution methods. So the popular one is closed circuit helium dilution method. The other one, which is widely used, is a body plethysmographic estimation. Now, what body plethysmographic estimation does? It measures the thoracic gas volume. So that will be the total gas volume, including communicating and the non-communicating airways. Whereas the gas dilution methods only tell us about the communicating parts of the lung. So, for example, if there is a large bulla which is not communicating, then the body plethysmographic volume will be much higher than a gas dilution estimated volume. So that is one of the major clinical applications where we can use both the methods and estimate the volume of the bulla.
Correct.
Otherwise, we use these estimations for further refining lung function abnormalities like defining air trapping or hyperinflation. But it is not mandatory that all patients of asthma or COPD should have lung volume. If facilities are available, one can go ahead. But clinically also one can judge whether hyperinflation and air trapping are there. But these are useful indices, especially in research parameters or when you're doing pulmonary rehabilitation to see how they are responding. And then selecting patients for surgery. So these are some of the clinical applications.
Wonderful, sir. Thank you very much. This was very, very clinically useful. Dr. Amit, quick answer, just like sir gave. In which condition you will prefer which inotrope? If the patient comes in sepsis, what is the inotropes of choice in order?
Yeah, fine, ma'am. So I'll just take 2 minutes and I'll just show 2 slides and summarize it accordingly. So if we talk about inotropes, basically there is no wrong answer in this. So we have to just understand that inotropes mainly are of 2 different categories. One is inoconstrictor, that is norepinephrine, epinephrine, dopamine, which are mainly a beta to agonist level, and which plays a role by increasing the cyclic AMP levels, whereas there are other inodilators like dobutamine, milrinone, and levosimendan. Now, when we talk about different clinical conditions, we have to understand if a patient comes in shock, any kind of shock, the first drug of choice is noradrenaline, simply because it is an inotrope, it is a vasoconstrictor, improves the peripheral pressures, as well as it has got lesser side effects compared to other inotropic agents. If in a patients who have got acute heart failure, we have to understand patient who comes with acute heart failure, only those patients who have wet and cold patient, that means patients who are congested as well as who have got poor peripheral perfusion, the role of inotropes are there. Especially, you have to see if the pressures are less than 90. Again, inotrope is the first in which noradrenaline becomes the drug of choice. If the pressure is more, inotropes are still useful if the vasodilators and diuretics are not happening. But if the pressures are better, dobutamine is a better drug, because dobutamine, being an inodilator, it has caused inotropy, that is increasing the cardiac contractility as well as decreasing the peripheral pressures, therefore decreasing the afterload. So inotropes, I'll just summarize with this slide. So you asked about different condition. Any patient who comes with hypotension, the inotrope of choice is noradrenaline. If after that the pressure improves slightly, we can go with dobutamine, and later on add dopamine or other vasopressors like vasopressin. When patient is already on beta blockade, the inotropes we have to avoid is dobutamine, because dobutamine has competitive antagonism against the beta blockers. So in such cases, giving drugs which are less dependent on beta agonist activity like levosimendan and milrinone are commonly used. Patients who have got pulmonary hypertension, again, pulmonary hypertension patient, levosimendan and milrinone have got better effect. Patients who have got cardiorenal syndrome, even though the studies have not shown that dopamine at low dose improves the renal perfusion, clinically we have seen a lot of patients, if we use low dose dopamine of around 2.5 mics, they do respond. Heart failure patient of ischemic etiology of heart failure, one thing we have to remember is milrinone is detrimental. If at all pressures are better, you go with dobutamine, levosimendan. If the pressures are less, noradrenaline is a drug of choice. Sepsis, always inotropic drug of choice is noradrenaline. If the pressures are still not improving, add on another inotrope like dobutamine. If the patient has got refractory hypotension where it is not improving, we can go ahead and start either epinephrine or vasopressins in such cases.
Okay, wonderful. This was concise and short. Thank you so much. I'd like to come to Dr. Ankita. Again, quick like others. What are the effects of altitude on patient of COPD? If they want to go to Leh Ladakh, or what is the effect? Can you please unmute yourself?
Ma'am, normally when a healthy individual is exposed to high altitude, the first response would be to increase the minute ventilation by the person. And the pulmonary circulation, also there is a hypoxic vasoconstriction, so that the blood is directed towards the well-ventilated alveoli. The person tries to, physiologically, they increase the cardiac output and try to increase the erythropoiesis, and sleep is affected, and there is periodic breathing, sleep and periodic breathing. In COPD patients, when we're talking about, already the patient is in hypoxia, so the patient, ascent affects the steep portion of the oxyhemoglobin curve. So there's going to be a more severe fall in the saturation, which leads to the dyspnea and other symptoms. We can assess this by exposing the patient to hypoxic challenge test, which is available at specified centers only. So the patient is allowed to breathe 15% of oxygen, and then we subject for a 6-minute walk test and look for the fall in saturation. So according to that hypoxic challenge test, we can actually segregate the patients and accordingly go for supplemental oxygen for patients whose saturation drop below 84% or 50 millimeters of mercury. Mechanism per se would be hyperventilation, that is going to worsen the dynamic distension and increase the work of breathing in these COPD patients, as well as the hypoxic vasoconstriction is going to increase the pressure on the right ventricle because of the increase in the right ventricular afterload, causing dysfunction, and the pH can worsen. COPD with altitude can worsen the symptoms of angina, and there could be exacerbations of arrhythmia as well. And another problem that can happen is the risk of venous thromboembolism and the risk of pneumothorax, which happens on high altitude ascent for COPD patients. So it is better to identify these patients based on the challenge test and segregate them and advise them for oxygen, give them prophylactic acetazolamide, which is the carbonic anhydrase inhibitors, go for pulmonary rehabilitation and muscle training before the patient can be subjected to a high altitude.
Wonderful. So we have a high altitude simulation test where patients are made to sit in a laboratory where less oxygen is given. Often we do this, when patients are hypoxic, they need to take a long plane journey. So this is very, very useful. Thank you, Dr. Ankita. Dr. Jagadamba, very, very quick, please answer. What is the effect of central obesity on lungs as compared to chronological age?
Actually, why I put up this topic is I did a study on this lung age in years in young adults, looking at their obesity by calculating conicity index, which is index of like BMI. This conicity index indicates the central obesity. So, obesity is abnormal excessive fat accumulation, as we know. Central obesity explains the reduction in chest wall compliance, respiratory muscle strength and functional, and lung volumes and peripheral airway size found in obese individuals. It alters the pressure volume characteristics of the thorax and restricts the descent of the diaphragm, decreasing the lung expansion. Coming to lung age, why I took up is this indicates it refers to the average age of a non-smoker with forced expiratory volume at
Can you
once.
just tell us the quick answer to this? Like central obesity, is it going to change the chronological age related lung?
Chronological age is, suppose I am 45 years. When I measure the lung age in the spirometry, it shows the actual lung age, not the chronological age. That's what it is. They have correlated with FEV1 also. Other studies, they have correlated with FEV1 and the predicted equations, which is imbibed in the spirometry itself. It gives the calculation itself, lung age in years. So lung age in years, what we get in the spirometry is the lung age, the chronological ages. So it is easy for us to tell the patient that instead of telling FEV1, which is a complicated version, this lung age, if we tell them that your lung is aged compared to your actual age, be careful and do this breathing exercise, whatever the interventions, we can make it. That's what I mean by this. That's the thing.
Wonderful, because the thing is that when we talk about PFT, we basically say age of the patient, height of the patient, ethnicity of the patient is going to make the difference. The weight is not really considered. So your equation is extremely useful. Thank you so much for talking about this. We still had 900 plus people logged in, but I think best to wind up. We are nearing 9:45. So last question to Ria, Dr. Anuradha. Very interesting one. What is the physiology behind respiration and maintenance of ventilation in relation to CNS depressant drugs, including benzodiazepines, barbiturates, Z drugs, and ethanol?
So you'll forgive me if I change it a little bit. Being old-fashioned, I thought of barbiturates and benzos and things like that. But then in today's day and age, we know that barbiturates, benzos, alcohol, all these drugs do have a depressive effect on the central nervous system. And being pulmonologist, I think for us, the most important question is, if I have a COPD patient or an asthma patient who's anxious, what drug would I give? And then you look at the SSRIs, basically the SSRI group. You look at Prozac, you look at fluoxetine, you look at Certa, because these are the drugs which will not depress respiration. If I am an asthmatic or a COPD or an ILD patient and I'm depressed, then what drug would I give? So then the SNRIs are very good for depression. Basically, there are DORA drugs that are available and they are good for treating depression without causing problems in ventilation, and it's available in India, and it's called lemborexant. It's available as 5 to 10 milligram, and you use those drugs for that. Now, if you have a patient who has convulsions and who has a lung problem, okay, whatever it may be, sleep apnea, it may be COPD, ILD, then what would you give? You wouldn't want to give the phenytoins and the valproates and the the drugs that we used to give in the past, barbiturates, but there are better drugs that are available for that also, and they're the second and the third generation anticonvulsants that are there available in the market. You'll excuse me, which I don't know the names too well because I don't use them so often. I send them to the neurologist, but they are lamotrigine, topiramate, lacosamide, and those are the drugs. So alcohol, opioids, barbiturates, benzos, generally do not give in patients who have respiratory issues. Try and avoid them. If you have to give a benzo, give clonazepam, short-acting, sublingual, 4 hours, the action is gone. And I'm going to end by saying that if your patients do want to drink alcohol and there is a COPD or an asthmatic or a sleep apneic, you tell them to have alcohol at 5 in the evening like people do in the Western countries, because before you go to bed, you'll probably metabolize the alcohol and it will not cause inhibitory effects as far as the brain is concerned. Yeah. Thank you.
Yeah, thank you. This was very, very clinical useful. So basically alcohol, if they want to only have then 4 hours before sleep time, as rightly Dr. Anuradha said, so that it's metabolized. If you tell a patient of sleep apnea, is not getting sleep when you want to do a sleep study, and therefore you need to give a sleeping pill, then zolpidem would probably the safest because it not affect your results. So I think we've had really a fantastic, enlightening webinar, with the last round of question being really like buzzer rapid fire questions, which each of our panelists have responded to and answered very, very well. So thank you very, very much for this fantastic webinar, for this huge amount of information that you all have given me, because I've learned so much, and it's going to really help my practice. It's really going to help my patients. I'm really grateful to each of you all, Dr. Chhabra, Dr. Anuradha, Dr. Amit, Dr. Jagadamba, and Dr. Ankita, for giving wonderful information. I really enjoyed being here. Thank you very, very much, Team CCI, Dr. Krishna, Dr. Atri, Dr. Kirat, Dr. Shivani, Dr. Vijay, everybody. Thank you very, very much for thinking about this fantastic topic. And with this, we'd like to wind our webinar. Thank you so very much.
Thank you, Dr. Nene, for excellent moderation.
Thank you. Thank you. Thank you very much.
Amit wants to say
Good night,
something.
everyone.
Yes, Dr.
Thank you very much.
Ma'am, there were some questions in the chat, so we still had 5 to 10 minutes. Can we take?
I think that we should just end, because normally the webinar is till 9:30, and what we'll do is that we'll request we'll probably directly reply to people, because actually there were just so many questions which I have tried to take, but I think we won't be able to take up everything.
Okay.
So thank you so much. Really.
Thank you very much.
Thank you, ma'am. Thank you.
Good night, everybody.
Bye. Good night. Bye.
Bye.